Okay. Left off on Friday, talking about the cardiovascular system, talking about stroke volume, right? Why did I say stroke volume in people that are the same age is the best predictor of aerobic fitness, or who might win an endurance race?
How much blood is being pumped out of the left ventricle to the rest of the body.
Okay. It does that, yes. How much blood is being pumped? Why is that important? Okay.
Probably more aerobically trained.
Okay. That's a thing that is correct, but we're not quite there. We kind of have it backward. But what else? Okay. More blood is more oxygen to the muscles. Okay, good. Linda, you're going to say the same thing. Okay. Larger stroke volume means larger, we're going to get to the next slide, cardiac output. Okay, larger cardiac output. Whoever has the highest max stroke volume among all of you guys who have the same basically age predicted max heart rate will have the largest cardiac output. Okay, so keep all of this in mind. Okay. Oh, no, I actually changed the order of the slides this year. That is on me. So we're going to do blood pressure next. Ha. Okay. Done things in one order for like 20 years. I'm like, no, cardiac output's coming next. And I forgot. I changed it. Okay. I know you guys have had blood pressure before, right? You guys know how to take blood pressure? Joey does not know how to take blood pressure? Never done it? Okay. Well, you all should get a chance. If you have it in one of your other classes and labs. This is the pressure exerted by blood in your arteries. Okay. We measure it in the arteries, exerted by the blood on the vessel wall. Okay. On the vessel wall. And so we typically express it as arterial pressure, most of the time measured in the brachial artery. We can measure it in any superficial artery that we want. We can try to measure it in the aorta if we need to. And we express blood pressure in two numbers. And I'll explain what these are, but then we'll talk about why blood pressure is so important afterward. Okay. Systolic blood pressure is the larger of the two numbers. This is the pressure the blood in your brachial artery exerts against the wall of that artery when the left ventricle is contracting during ventricular systole. Okay. It contracts, it pushes blood out, that volume of blood goes up, that drives that pressure up. Okay. Diastolic pressure is the pressure when the left ventricle is relaxed. Okay. During filling of the left ventricle, that's going to be the lowest of our pressure. You may think, okay, well, that's great, that's super obvious. Why do we care? Okay. And one of the more magic kinds of things that happens in physiology, your blood circulates through your body based upon differences in pressure. Okay. Differences in pressure. So high pressure over here in this corner. Okay. Low pressure over here. Blood wants to move from this side of the room this way to the area of lower pressure. And then it gets over here and ooh, it's even lower if I go this direction towards you guys out here, then it wants to go like that. Okay. All movement of fluid, not all, most movement of fluid, especially blood in the body, is across a pressure gradient. So when the left ventricle contracts, it raises the pressure in the ventricle. Blood moves from a high pressure in the ventricle to somewhat lower pressure in the aorta, and it moves like that. Then pressure falls as we get away from the heart, and it moves from high pressure to low pressure. This is what drives all movement. Okay. So there's an older variable, and people don't do this very often. If you go to the doctor, you go to a clinical setting, you may see it's called mean arterial pressure. It's meant to be the average pressure experienced in a vessel across an entire cardiac cycle, across a period of diastole and systole. And so it is in essence at rest, we calculate it as right? Diastolic pressure plus a third of the difference between systolic and diastolic. So it's basically taking systolic pressure, counting it once, taking diastolic pressure, counting it twice, under the argument that we spend about 2/3 of our cardiac cycle in diastole at rest. And that gives us our mean arterial pressure. Okay. This is going to fluctuate a little, and the contribution of each of them, the math changes as heart rate increases during exercise. So we kind of got away from doing this. But the big take home, okay? When we exercise, systolic pressure goes up. So if pressure in the heart goes up, there's a larger pressure gradient from the heart out to everywhere else. So more blood will want to move. Okay, more blood will want to move. In people that have high blood pressure, sometimes diastolic pressure goes up. If diastolic pressure goes up, then like imagine my aortic pressure at rest is rising because of atherosclerosis or something, then it narrows that pressure gradient between the ventricle and the aorta, or it narrows that pressure gradient between the aorta and the brachial artery and such. And as that gradient narrows, you'll get less blood movement. Okay. And then to get the blood to move, the heart has to contract more forcefully to raise ventricular pressure even higher over aortic pressure. So when people that are hypertensive, their heart is having to beat harder every time it beats. Remember, we talked last week about how many millions of times or hundreds of millions of times has your heart beat up to this point in your life, or will it beat across your entire lifetime? So if it has to work harder, that could be bad. Okay, that's why pressure is so important. I love this graph, even if I'm not going to ask you guys about it. But what you see here is in the left ventricle moving through basically aorta, arteries, arterioles, capillaries, veins back to the right atrium. And what it is showing you is the cyclic change in pressure during systole, diastole, systole, diastole. So you can see in the ventricle, pressure goes way up and then it falls way, way down. So it's easy to fill. Out here, okay, out here in the arteries, you get this cyclic change in pressure, diastolic. So here, here, and then it falls across the arterial tree, through the capillaries into the venules. And this is how we drive blood through our entire system. Okay. We're going to see with exercise. We make this part get higher, and we keep this end out here. We try to drive it down a little bit in the tissues where we want blood. So we have a better driving pressure. We drop pressure in the arterioles, bigger gradient, more blood goes where we want it to go. Okay. Everything moves in the system by pressure. Everything moves by pressure. Okay. So I could pick someone, again, make you stand up, tell us about the worst date you've had in your life or something. You get a little flushed, right? Dropping pressure into capillaries that go to your skin. Okay. Dropping that pressure. Blood goes there. Okay. You know why they tell you don't go swimming and for a little while after you've eaten? You go and you exercise, you raise the pressure in arterioles that go to your digestive system. So you cannot digest food and it gets trapped in there. It makes you feel sick to your stomach. Okay. So we'll talk more about how we sort of direct blood flow in different ways based upon changes in pressure. Okay. Okay, look, there's cardiac output. All right. There we go. Cardiac output, right? We talked about heart rate, we talked about stroke volume. Cardiac output, which weirdly is abbreviated as Q. Somebody maybe understands if that's Greek or Latin or some shit that I've forgotten. Okay. But cardiac output, very simply, is the product of heart rate and stroke volume. So how many times does the heart beat in a minute? How much blood does it eject every time it beats? That gets us, over the course of 1 minute, that gets us a cardiac output value. Okay. We typically express cardiac output like we express absolute oxygen consumption in the liters of blood per minute. So it's the volume of blood pumped, how much blood leaves the heart in 1 It tends to be in an average sized college age person about 5 to 6 liters per minute rest. You guys know how much blood you have in your body? Wild stab. 5 to 6 liters. Okay. Some of y'all that are a little smaller, maybe it's more like 4 to 6, somewhere in there. Okay. You typically, cardiac output in most people is not that far off of your actual blood volume at rest. So you are in essence circulating all the blood in your body through the heart about once at rest. Okay, every minute. During exercise, because we can make heart rate go up and we can make stroke volume go up, we can take the cardiac output from about 5 or 6 up to about 20. In some people, it may get into the 30s. Okay, we can raise cardiac output 4 or 5 times over its resting values during exercise, which means we're just moving more blood, more and more and more around, so we can bring more oxygen, bring more things to our tissues. Okay? That is cardiac output. You'll see it later on, probably on Wednesday, but I will tell you right now, if we do a relationship graph with VO2 max, maximal cardiac output is the thing that most highly correlates to maximum oxygen consumption. Okay? As exercise intensity increases, cardiac output increases almost exactly linearly, like in a one-to-one relationship with all of that. So this is a really, really, really important parameter for determining exercise capacity. Okay. Okay. Cardiac output is one of the tightest regulated physiological parameters in our body. We have a finite amount of blood. We have a finite capacity to put oxygen into that blood. So we need to tightly control how often that blood circulates and where it's going to make sure we are getting oxygen to the correct tissues, okay, while also keeping things going to the brain. So I'm going to break this down in this particular way. I don't know which of these terms you guys may or may not have seen before, okay? But if we look at the things that determine cardiac output, we're going to talk about how we change and regulate cardiac output by examining how we change and regulate the heart rate component and how we change and regulate the stroke volume component of everything. Okay, so what we're really going to do is look at what happens with heart rate, how do we change heart rate, how do we regulate heart rate, and how do we regulate stroke volume, because the two of these things in combination get us this. Okay, we're going to start with the much more simple one. How do we change heart rate? Okay, how do we change heart rate? Relatively simple, relatively straightforward. Okay. Intrinsic firing rate of the SA node is usually between 60 and 80 beats per minute. Okay. Leaky calcium channels, leaky sodium channels. This is what's going to happen, right? You're super sedentary, or you're really stressed out, or you've had a bunch of caffeine or something. Although the caffeine doesn't do that much at rest. Caffeine really only exerts its effects on heart rate once you start exercising. It sort of augments the sympathetic nervous system response, which is kind of a fascinating thing. You may be in the 30s or 40s or the high 20s and highly trained people up to 100 and people that are relatively sedentary that are going to be here. During exercise, heart rate increases in direct proportion to intensity. This is why we use heart rate as a way to monitor and prescribe how hard you're working. That's why all of your watches and things will measure heart rate, okay? Although if you're me, mine is weird and doesn't work right. Not maybe the watch, but also my heart rate regulation doesn't, okay? Heart rate changes really, really fast. As you go from rest to standing, to walking, to jogging, to any kind of all-out exercise, heart rate will change within 5 to 10 seconds, okay? It's very, very fast, okay? Very fast. It goes up And then if you maintain that sort of whatever that work rate is, it goes up within 5 to 10 seconds and then it should level off. Okay. So if I go from rest to walking, within a couple of steps, it's reached and it's immediately gone up from say 70 beats per minute at rest to 100. It's going to stay flat right there as long as what my walking pace is the same. Okay. Unlike other parameters, heart rate changes really, really fast. Okay. So it's here. Any of you guys ever monitor your heart rate when you're exercising and try to check and do those sorts of things? Okay. We should have talked about it with Epoch. Anybody ever been to Orange Theory and done that? They monitor your heart rate they don't do their calculation as sort of accurately as the physiologist would prefer, but it's a very useful kind of thing. And they make a big deal about the Epoch and all of it. You can use it really, really, really easily. Okay. To understand what happens and how we do heart rate stuff, you guys need to be able to calculate age predicted max heart rate, which is 220 minus your age. There's this other equation, which is about 207 minus 2/3 of your age. Again, you get a number that's within like 1 beat per minute of the thing. We're never happier as scientists when we take something that works perfectly well and try to make it more complicated to be like 1 beat per minute off in the midst of all of that. A thing to keep in mind. Max heart rate does not change with training. You cannot train and make your max heart rate go up. It would be great in some ways if you could, because that would be able to raise your max cardiac output, but you can't. Okay, but you can't. Now, you get to be my age or really my parents' age. Okay, and if you're very, very well trained, you do not see as much of a decline in age predicted max heart rate if you're very well trained and you're older. Okay, if you're very well trained. So that's sort of what's going on there. Okay, so let's talk about how we regulate heart rate and why it goes up so fast during exercise. Okay, there is a concept of something called extrinsic regulation. Extrinsic just means this is something from outside of the heart, outside of the SA. Okay. We're going to get things in the cardiovascular centers in the brain. They're going to control autonomic nervous system input. Okay. Primarily, we're going to use epinephrine and norepinephrine to increase heart rate, and then parasympathetic input from acetylcholine to decrease heart rate. Remember on Friday, we kind of did a little meditation, some deep breathing. We were trying to lower epi and norepi, and by breathing, to release acetylcholine. So we were trying to drive it down like all of this, okay? Large numbers of sympathetic and parasympathetic neurons innervate the SA node and the atria, okay? So you're going to get parasympathetic and sympathetic in the atria. We're going to get mostly sympathetic on the ventricles. That's going to become important, okay, because of the job of the ventricles versus the job of the atria. Okay. What this leads us into is we control heart rate with parasympathetic and sympathetic input, but we control contractility or how hard the ventricle contracts simply with sympathetic input to the ventricle. Right. So that's what kind of what's going on. All right. A difficult concept that I need you guys to try to understand here. Okay. A difficult concept. The first way, don't let me back up. That's not going to be where to start. Okay. Most of you right now, as you sit there, okay, you don't have to have a show of hands, but some of you may be like me, maybe a little anxious. Right? But most of you have a predominant amount of parasympathetic input to the SA node right now. Okay? Right now. So when I do something, everybody stand up, go up, start walking in place just a little bit. Walk, come on. Okay? Walk, okay? Good. All right. Stop. We raised your heart rate as you stood up and started walking. Okay. Because parasympathetic was predominant at rest, what we did to make your heart rate go up was not to release epinephrine and norepinephrine. What we did was stop inputting acetylcholine. Okay, so the initial rise from rest to very low intensity exercise is not epi and norepi, it's the withdrawal of acetylcholine. Okay, you stop getting that, and by removing it, that actually raises your heart rate, which is gonna feel a little bit backwards, right? Gonna feel a little bit backwards. Now, the initial thing you got up, we pulled, we sucked the parasympathetic away. Now, jog, jog. Okay, a little more, okay, jog, yeah, I'm not seeing it, come on, guys, jog. Okay, stop, you can sit back down. When we start doing that, we've taken acetylcholine away, that raised your heart rate to a certain point. To get it to go up even more, we can't take away more than 0. So now we have to start adding epinephrine and norepinephrine on top of all. Okay. And so the primary way that we initially regulate heart rate, if we need to only raise it a little bit, pull parasympathetic away. Then we start adding epi and norepi on top of all of that. And I'll be really honest, I'm going to show you a graph and it looks like it's that completely like kind of cut and dry. It's kind of like metabolism that we're always pulling the parasympathetic away. We maybe also putting a little bit of epi and norepi in. It's kind of the balance of the two. But it makes sense to try to present it in this particular way. Okay. So if you look at this graph on the bottom first. Okay. Here we are at rest. Heart rate, say 50 or 60 beats per minute. If I want to raise it up, and don't get caught up on, well, does it raise it to 100 or 110? The number is not important, but it's this process. Okay. We get parasympathetic input to the heart from the vagus nerve. You don't have to know that. I'm not going to ask about the vagus nerve. Okay. Much to Cindy's chagrin, we're not going to talk about the vagus nerve. But I remove acetylcholine from the vagus nerve, and that raises heart rate. Then we start to add epi and norepi, and that raises it up even more as we go from rest to walking to jogging fast, to kind of all out exercise here. Okay. This graph shows kind of the general kind of inputs on all of this. That's what we're talking about. Okay. The top part of the graph shows you, right, parasympathetic innervation from the vagus nerve, sympathetic innervation, okay, down here from these other centers. And you will note that parasympathetic is only going to the atria, and sympathetic goes to both the atria and the ventricles. Atria and the ventricles. Because the sympathetic does two things. It helps us to raise heart rate, but it also makes the ventricles contract more forcefully, which we'll get into when we talk about stroke volume regulation. Okay. I want you all to know that. Where does parasympathetic go and not go? Where does sympathetic go and not go? Because again, this is structure. This is anatomy imparting how we use each of these neurotransmitters to alter these cardiovascular parameters. Okay. Okay. This is just going to show kind of the response and the mediators of some of those things. We also, outside of that sort of input from those centers, we also are going to get a little bit of peripheral input. Okay. There's peripheral receptors in blood vessels, in joints, and in muscles. Okay. They are sensitive to both chemicals, so biochemicals, metabolic byproducts, those sorts of things, and mechanoreceptors. So they sense changes in position, they sense muscle contractions, and they are also, this peripheral input from these also signals back into the cardiovascular centers and can help us to regulate sympathetic and parasympathetic stuff. And they're going to help us try to match cardiovascular and respiratory things. A lot of this also signals into how we change breathing. And we got to be very careful about matching breathing to cardiac output, which we'll get into at the end of this week. Okay. Okay, wait, I forgot to remove stroke volume from there because I had moved it on. So that's how we use heart rate and raise and change heart rate to contribute to our change in cardiac output. How we regulate stroke volume is more complicated. There's more things that play a role in stroke volume. Okay. And because of all of that, we need to really understand them, because stroke volume, in those of you guys that are the same age, this is the thing that's going to be different. Okay. The first thing that controls stroke volume is something called preload. Okay. Preload. Another name for preload is venous return. Okay. Is venous return. And I should say that that's probably not actually the most accurate thing. So let me do this. Okay, guys. Strike what I just said. Preload is end diastolic volume. Preload is the amount of blood in the ventricle before it contracts. Okay. This is primarily determined by venous return. Okay. Primarily determined by venous return. I had a student in class a few years ago who, on the first day of class, said, Dr. Black, sometimes I have dysregulated sympathetic and parasympathetic function, and I will just randomly like faint and pass out in class. Sure enough, on the first day of class, that's exactly what she did. Okay. When somebody passes out, you guys remember your first day, what do you do with them? Pardon? Put them on their side. Okay, we check the airway, we clear the airway, right? That's doing, they're conscious. Legs above our head. Why?
Get more venous return.
We get more venous return. Gravity affects venous return. If I flip all of you guys around, stand you up on your head. Okay, we do that. I'm going to do a handstand. We use gravity to pull blood back to the heart, and we increase preload. We increase venous return. Okay, so preload, the more blood that goes into the left ventricle, the more it stretches. Okay, remember, cardiac muscle works just like skeletal muscle. So what do I do when I'm going to do a vertical jump? What's the first thing that I got to do? Right? Stretch, eccentric, concentric. Okay, that gives me more force. Same thing happens in the left ventricle. I put more blood in and it stretches out the ventricle. And then when it goes to contract, it gets the force from the cardiac muscle plus that elastic component from the stretch. Okay. You guys probably learned that in human phys as something called the Frank-Starling mechanism, or the Frank-Starling law of the heart. Okay. And this is why preload is so unbelievably important. Okay. Is what it is basically is there's a relationship between how stretched the left ventricle gets. And that stretch is determined by, you can call it end diastolic pressure, or it's basically end diastolic volume. Because as volume goes up, end diastolic pressure goes up. The more blood that comes back, the more the walls get stretched, the harder or more forcefully it contracts, therefore the more blood that gets ejected. You can do a graph that looks like this. Ventricular performance simply is stroke volume. This is stroke volume graphed against ventricular end diastolic volume, or preload. So the more preload we get, the larger the stroke volume we get, because up to a certain point, it stretches and it contracts more forcefully, so more blood goes out. Okay. Increasing preload is probably the single most important way to maintain or increase stroke volume during exercise. Okay. Anybody ever done like an all-out race and they tell you to walk afterwards, and you're like, well, the last thing I want to do right now is to walk and to do those things, right? If you don't, you're gonna pass out, because all the blood is in your legs, and when you stop contracting, venous return falls, so end diastolic volume falls, so stroke volume falls, and so then blood pressure falls, cardiac output falls, and your brain is unhappy and it says, pass the fuck out, right? Go down so that we're not fighting gravity anymore, right? That's why this is so unbelievably important, okay? I've made a list here of the things that we know that affect preload and therefore affect stroke volume, okay? Venous return is the biggest one. Cardiac output, when it goes up, drives greater venous return. Posture drives greater venous return. Basically, all of these things are going to get back to venous return. Okay. If you have more blood, you get a greater venous return. Okay. I infuse every one of you with a bag of saline right now, and it makes your stroke volume go up because you have more blood. Even though your blood is less concentrated, you've got more, it will raise stroke volume. Okay. You have a thing we'll see in the next slide called the muscle and the thoracic pump. Okay. When your muscles contract, they squeeze your veins. And they squeeze your veins and they force blood back to your heart. And that's why after exercising, you got to keep walking because you need those muscle contractions to squeeze blood back to the heart. There's a thing called the thoracic pump. And you expand your chest cavity. It lowers the pressure inside here, which actually lowers the pressure in the inferior and superior vena cava, which makes it easier for blood to get back into your chest cavity and return to the heart. Breathing deeply, in essence, creates suction, pulling blood back in towards the heart. So, any question?
Is that why whenever like sports they tell you don't like be on your knees to let you stand straight up?
Yes. It's easier to breathe that way too, but also, yes, you're not compressing your chest cavity. Okay. Posture matters greatly. Okay. Heart size also really matters. If you have a bigger heart and a bigger left ventricle, we can put more blood into it, the stroke volume goes up. And then the thing that's hard to measure, but I just want to mention is something called venous tone. This is the only acceptable use of the word tone in this entire class. Okay. Tone has nothing to do with your damn muscles. But what it means is the extent to which you are able to somewhat, and it's hard to do in veins, but sort of alter the kind of constriction amount or relaxation amount in those veins. Okay. If you squeeze the veins just a little bit and make them a little bit smaller, it raises their pressure and it drives more blood back to the heart. Okay. So this is just kind of showing all of these things together and how it all interacts. Okay. But the big thing is all of this stuff here, 2 through 6, increases venous return, which increases stroke volume by increasing preload. Okay. This is a graph of the muscle pump. Okay. Here's a vein. Here it is around the muscles, right? You can see it in your forearms. You probably can't see my veins. Probably don't want to see my veins, but I can. You squeeze, right? And the muscles around those veins squish the veins. Veins have valves, so blood can only move in one direction. They can't go backwards. So when it gets squished, it raises the pressure and it forces it forward back towards the heart. Right. That's why you've got to keep exercising. You've got to keep walking after we do things. Okay. So if that's the biggest one, one of the next things, and it's not a big deal in you guys, but it's going to be a big deal in older folks, is something called afterload. Preload is in diastolic volume. Afterload is in essence in systolic volume. Okay. Afterload is when afterload rises, that means less blood left the heart. When afterload falls, it means more blood left the heart. Okay. Primarily, afterload is controlled by aortic blood pressure. Okay. Especially aortic diastolic blood pressure. So what this means is if you've got a person that's hypertensive, and they can't lower their aortic pressure enough, then the gradient falls and blood won't leave. Blood doesn't leave from there. The primary thing that you guys do that alters afterload, and I had this conversation with somebody in my office the other day. I think it was with Christina, Joe, maybe with you in there. Okay, you guys taking personal training or something? You guys talk about doing a Valsalva maneuver. Okay, and it says, and this is the dumbest thing to try to execute ever, right? It's like do a squat, but breathe while you're squatting. Just seems completely counterintuitive, right? When you lift a heavy weight, you contract here, so you don't smush your internal organs, right? But it's like, okay, breathe in while I'm going down. And then breathe out while you go up when you do a squat. If you can breathe out while you're doing a squat, put more fucking weight on there, right? That's all I have to say. That's the most counterintuitive thing to me. But what happens is I contract here, and it dramatically raises intrathoracic pressure. Blood pressure goes through the roof. When you Valsalva, you may get pressure that's like 500 over 300. Okay, it's giant. And so basically blood can't get out of the heart while you're doing a Valsalva, so afterload's really fucking high. Okay, but right, it's down, you're like, okay, 2 seconds or 1 second, I did that. Now breathe and we're fine. And then we're here. Okay. Anyway, the breathing thing kind of freaks me out, but that's what's going on. Because of this, in clinical populations, in people that are older, in people that are hypertensive, if you're going to exercise them, if you're going to rehabilitate them, we don't want them holding their breath. We don't want them doing isometric contractions because they Valsalva more. It raises their blood pressure. And we're not so much worried that their stroke volume falls. What we're worried about is they Valsalva, their pressure goes through the roof, and they have a stroke, or they blow out a blood vessel somewhere in an aneurysm, then they die. Okay, that's the big thing that's going to be. Okay? That's afterload. That's afterload. Okay. Another thing that determines stroke volume, okay, is sort of related to one of the same concepts from preload, but we're going to be more specific, okay? And that's contractility. If there's a certain amount of blood in the ventricle and I make it squeeze harder, more will leave, okay? More will leave. And so what we see with contractility, okay, there are other things beyond preload that can alter how forcefully it can contract. Okay. One of those things, all right, is going to be sympathetic nervous system input. Okay. When you get increased contractility, you can increase the stroke volume. So when we put epi and especially norepi in onto the ventricles, it makes contractility go up and it makes stroke volume go up. Other what we call inotropic agents, things that mimic that, like potentially caffeine, okay, are going to make that go up. Hypoxia, if you make the heart ischemic, that's not good. Okay. But when the heart is ischemic, it will make contractility fall. If it becomes acidotic, you get acidosis, right? Mostly because it's ischemic and you're making lactic acid, it's going to fall. Or if we get tissue death, this is the other piece that can be a longer term thing. Okay. If you have a heart attack, there's enough hypoxia in a large enough area, you will get cardiac muscle that dies. And when it dies, right, if it's in the ventricle, now that ventricle does not have as much many sarcomeres, it can't contract as forcefully. And so now stroke volume has fallen. And so now post a heart attack, your cardiac output is down. Okay. And in some instances, if enough of it dies, it can't contract forcefully enough. It's hard to overcome blood pressure, aortic blood pressure. And so now it's hard to get blood to leak. That's called congestive heart failure, right? It cannot contract forcefully enough to do those things. The beauty of all of this, though, is that cardiac muscle is like skeletal muscle. We'll just keep working it, even after some of it's died, it'll come back. It'll grow. Yeah. It's muscle like all the other ones. And so this is why now for people that are post-heart attack, something called cardiac rehabilitation is the standard of care. If you like working with older individuals, go learn how to read EKGs. You can become a cardiac rehab sort of person and work in a hospital. There's all sorts of stuff that goes on with all of that. Okay. Actually, to be honest, if anybody wants to do that, I have a job. There's a hospital that sent me a thing that they call them exercise physiologists now, but you do cardiac rehab. You train people, you watch them while they're on the treadmill. Because when we've had a heart attack, we've got to retrain the heart to try to make it grow so we can get our contractility back. Okay. All right. The very last thing, and this only happens during maximal amounts of exercise. Okay. So this is the least impactful of all of these things on our stroke volume. But heart rate can play a role in stroke volume because heart rate, especially very high heart rates, can begin to limit venous return, and they can therefore limit preload. Okay. And what this means is, remember we talked on Friday about as the cardiac cycle goes faster and faster, every heartbeat, the amount of time for a heartbeat shrinks. Okay. And so as it shrinks, the amount of time we have to physically put blood into the ventricle goes down. Right. So remember, if here's rest, okay, and there's diastole and there's systole, and it looks like so. During very high intensity exercise, the entire cardiac cycle is shorter than what diastole was, and it starts to look something like this. Okay. And so if maybe this was, let's just call this 0.6 seconds, it may shrink down to like 0.2 seconds. And so by there being less time for blood to go in, we may not be able to sort of reach the amount of preload that we could at lower heart rates, which may then limit end diastolic volume and stretch, and therefore limit stroke volume. Okay. I will illustrate this with a graph from the study from 1992. You guys want to know how are they measuring stroke volume? They ran a central line into these people's aorta and said, get yourself on a treadmill, and we're going to do a VO2 max test while you're running with a central line in, so they can directly measure how much blood is coming out into the aorta with every heartbeat. Okay, so here's rest. Here's 50% of VO2 max, and then here's max. They actually took these people, these are the same people, and it was before and after like 16 weeks of aerobic training. So they were looking at the training response. What I want you guys to look at is the white circles. This was pre, these people are sedentary. See how stroke volume goes up as you get to about 50% of max, so kind of a nice light jog. And then at max, stroke volume has actually gone down. Heart rate is so high that we can't feel it as the stroke volume falls. Then when they trained them, they got better. And so max stroke volume goes up, but they got less of a fall at the end. They were better able to kind of keep it flat like all of this. Okay. So it only really matters at very, very high exercise intensities, but especially in untrained or sedentary people, high heart rates limit preload, which therefore limit stroke volume and limits VO2 max and exercise capacity. Okay. So again, we've got to understand the mechanics of how all of this works. Okay. We have just a couple of minutes. I'll very, very briefly talk about blood vessels. Then we'll do more on the blood vessels, their importance on Wednesday. Okay. 3 broad categories of blood vessels: arteries, capillaries, veins. Technically, right, we're going to break arteries into big conduit arteries and then into smaller arteries, which we call arterioles. Then we have capillaries. Then we have small veins that are called venules. Then we have big veins, conduit veins. Okay, we're going to go across all of these. All of these are very, very, very important. Okay, the one we're going to spend the most time talking about, though, is going to be arterioles. arterioles and arteries, but especially arterioles, are really important for controlling where blood goes in your body. It's not enough for us just to be able to raise cardiac output during exercise. We also need to be able to, as cardiac output goes up, send the cardiac output to the tissues that need it and send it away from the tissues that don't need it to help us to exercise. And we use arterioles to do that. Right? And they have a very special structure. Arteries and arterioles do. We're going to focus primarily on how it functions in arterioles, called vascular smooth muscle. Vascular smooth muscle. So you have a vessel, and then all around that arteriole, all around that vessel is smooth muscle, and it can contract and relax and make that vessel get bigger or smaller. By changing the diameter and changing the pressure inside of it by changing the diameter, we can either get more blood or less blood to go through those arteries. Okay. This is blood going away from the heart. You get to capillaries, they've got lots of holes in them. This is where all of the exchange with our tissues takes place, so it's really important. And then coming out of those, we're going to get stuff back into the veins to bring it back to the heart. Okay. All right, we'll stop there for today. I will see you guys on Wednesday.